Good afternoon, everyone. Welcome to our next session in our Boosters and Beyonds series. This week, we're going to be talking about gradual dose reductions. We have our esteemed speaker, Rob Aceta here, who is a senior pharmacist for drug safety and chronic disease management here with iPro.
Thank you, Josh. Nice to be with you this afternoon. A little bit about iPro and the QIN-QIO. So the iPro QIN-QIO is a federally funded Medicare Quality Innovation Network, a quality improvement organization in contract with the Centers for Medicare and Medicaid Services. There's 12 regional CMS QIN-QIOs nationally. And the composition of iPro, it's iPro, which concentrates mostly in New York, New Jersey, and Ohio. We also, of course, work with health-centric advisors, and those would be primarily the New England states, Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont, and Clarent, which covers Maryland, Delaware, and the District of Columbia. Next slide, please. So let's talk about today's learning objectives. Today, we will define the requirement for gradual dose reductions, or GDRs. We'll provide some illustrations of successful GDR protocols. We're going to present strategies that your nursing home could implement to improve your success rate of GDRs. And throughout the presentation, we'll provide resources and tools for your use. Next slide. So let's start with the definition from our CMS State Operations Manual of what a gradual dose reduction is. See, the gradual dose reduction for psychotropics, and very clearly stated, the facility is required to attempt GDRs, gradual dose reductions, unless it's clinically contraindicated for the resident. And in quotes, these two bullet points talk specifically about what the reduction should encompass. So dose reductions should occur, and the key word here is in modest increments over adequate periods of time to minimize withdrawal symptoms and to monitor symptom recurrence. And then we have an example in the State Operations Manual for folks to look at. So compliance with the requirement to perform a GDR may be met if, for example, within the first year in which a resident is admitted on a psychotropic medication, or after the prescribing provider has initiated a psychotropic medication, the facility can attempt a gradual dose reduction in 2 separate quarters with at least 1 month between the attempts, again, unless it's clinically contraindicated. So we have the link for you that takes you directly to the State Operations Manual. Next slide, please. And question comes up periodically, are all medications required to have a gradual dose reduction, any or all psychotropic medications? So there are some exclusions from the GDR requirements. I think those of us in long-term care facilities would be familiar with quality measure calculations and how this is generated. So again, the presence of diagnoses that exclude nursing home residents from CMS's measure of the use of antipsychotic drugs include the following, and these are the diagnoses and their families: schizophrenia and other diagnoses related to schizophrenia spectrum, Huntington's chorea, and Tourette's syndrome. And recently, CMS convened a technical expert panel to provide additional recommendations to help improve how antipsychotics are measured and reported for the STAR ratings. Next slide, please. So antipsychotics, gradual dose reductions, and CMS. And this slide is a reminder for us. Here we talk about the National Partnership to Improve Dementia Care in Nursing Homes. This was initiated in 2012. And at the time, there really was a heavy emphasis on ways to improve care for providing care to residents with dementia. And obviously, one of the primary concerns would be medications and trying to avoid putting residents at harm's risk. So this slide actually talks to us about the national partnership, and the highlight here would be that nursing homes can get support to improve resident safety, reduce potential harm, improve care, and reduce the use of antipsychotic medications by contacting the QIN-QIO, organization. So again, for us today, just to highlight that this is an ongoing effort, and this is actually coming directly from the CMS.gov webpage. Next slide, please. Now, in accordance with the National Partnership to Improve Dementia Care, the Office of Inspector General has been reviewing periodically the progress being made. And so Health and Human Services Office of Inspector General issued this report in November of 2022, so not that long ago, talking about psychotropic drugs and the trends of these medications and use in nursing homes. And so this is a pretty impactful report. Next slide, please, will give us a summary. So the findings of this report and the focus on psychotropic drugs, the OIG found that from 2011 through 2019, so just around the time COVID struck us, about 80% of Medicare's long-stay nursing home residents were prescribed a psychotropic drug. And then while CMS really was focusing on its efforts to reduce the use of one particular category, the antipsychotics, the study and the review showed that another category of psychotropic drugs, anticonvulsants, increased. So anticonvulsants are drugs not FDA approved to be used as a psychotropic, but they are used off-label in nursing homes and facilities. So this increased use of anticonvulsants contributed to the overall use of psychotropics remaining constant at about that 80% threshold. So we had improvement by reducing antipsychotics, but we also saw an increase in either what we would call category shifting or using category of medications that would not be FDA approved to treat residents who have expressions and behaviors. Next slide, please. So antipsychotics, again, focus because they're high-risk medications. So high-risk medications and adverse drug events are associated with the use of these medications. And primarily, we would be concerned with the following. So it's excessive sedation, confusion, orthostatic hypotension, and of course, the risk for falls increases with any of those three. Extrapyramidal symptoms, which include akathisia and dyskinesias, Parkinson-like symptoms, dystonias, and the increased risk for stroke or CVA. And based upon that information, we have a warning that's a requirement for all antipsychotics, whether they be the typical original antipsychotic class or the atypicals, because there's a 2 times the risk of mortality when these medications are used in the elderly with a diagnosis of dementia. Next slide, please. So a reference that I'd like to share, and I believe folks may be familiar with this, talking about the holistic approach for best practices and strategies on ways to reduce medications and implement gradual dose reductions comes from the Maine Dementia Care Partnership. The link is available right here on your slide. And again, this is an excellent resource that's provided a lot of information. And we will go to the next slide and give you an outline here on the what I call the dementia care change pathway. And you can see there's 8 areas that have to be for consideration when it comes to making a change. And you can see here, and I'd like to highlight the numbers here: the first line of defense, a therapeutic environment, the data-driven dashboard. Data is so important today. Obvious and demonstrated competencies to education, hospital transitions process, whereby nursing staff will review medications and make sure that, in particular, these medications are appropriate. Family education, a key component when it comes to any type of gradual dose reduction. And then here, the last 2, very important, the process for gradual dose reduction. It's really a community-wide commitment. And finally, physician, medical director, provider engagement. All of these elements are really critical to have successful strategies for gradual dose reductions. Next slide, please. Okay, so when we were looking at ways to implement gradual dose reductions and strategies, first things first, you need to identify a champion in your facility and create your team. So first of all, leaders should be identified, and these folks should be responsible for managing and monitoring your facility's gradual dose reduction initiative. And the folks generally who would be candidates for this champion role would be possibly your administrator, your medical director, director of nursing, consultant pharmacist, and any other person that's identified by the team. The leadership role requires authority with the expectation that folks who are working in this team will have accountability for the requirements of the teamwork. We start with a data-driven activity, and that means we collect reports of psychotropic medication orders, and these are generated either by the electronic medical record of your facility or obtained from your provider pharmacy, or possibly from your consultant pharmacist who can access the information and provide executive summaries and reports based upon medication classification. The process must incorporate an actual review of residents. So please remember, this is about the resident, person-centered care. It's not just looking at data and reports. It's using that information to help drive changes and recommendations. Next slide, please. Again, when we talk about data, we would really be remiss if we didn't talk about CASPER quality measures. So again, the CASPER report is a tool available, something that facilities should be focused on, in particular for this gradual dose reduction initiative to look at psychotropic medications. And that includes both short stay and long stay residents. Short stay residents may be with you for a brief period of time for rehabilitation, but several of them may convert over to long stay. So not only are they impactful to the measures, but also when they convert over to long stay, they really impact the quality of care that has to be provided to those residents. These CASPER reports and quality measures, they're going to compare your facility ranking to the national and state averages. At the time of this talk, the national average for the use of antipsychotics hovers at about 14.5% of residents in facilities. Your state will vary. And so, the question I have for you is, what are your numbers? You need to know your numbers, and who is monitoring this at your facility. So a minimum would be your administrator. Possibly it's going to be your medical director, specifically when it comes to the use of these medications. But we must ensure that this facility level data is shared with the team leadership and folks who are the key stakeholders on this team. And on this slide, I just included a new update here, that there's a resource just released June 20th for recording about the changes to the MDS, which will be coming in October. Next slide, please. So interdisciplinary team approaches before attempting GDRs, and this really bullet point list are some things that you would be familiar with, but it's helpful to review them because there might be one or two that your team would like to improve upon. So first, it would be the regular medication review at the time of an MDS evaluation. It's an excellent time when folks are looking and coding the types of medications and how many days and whether or not a person has been receiving the medication. Good time to ask questions at that review. Psychotropic rounds. This is something that's been some strategies that have been used by facilities, especially in facilities that have large numbers of residents receiving antipsychotic medications or psychotropics in general. These would be conducted by a clinical team, and these would include the medical provider, a nurse or the nurse on the unit or a nurse manager, social services persons, therapeutic activities, discipline, dietitian, and of course, the pharmacist should be included. Having telehealth, which is relatively new, one benefit that we've attributed after COVID, to have these conversations with consultant providers such as psychiatrists who might be doing reviews off-site if you don't have an on-site psychiatrist coming to your facility. And also with the family or the designated representative. These folks should be included and informed of any team recommendations prior to attempting GDRs to make sure they're informed and provide consent if the resident does not have capacity to do so. We would always advocate to implement the non-pharmacological interventions first before changing medications or adding medications, and review all psychotropic medications during the interdisciplinary team meeting, which usually are held quarterly. Next slide, please. So some reflections on person-centered care for anyone receiving psychotropic medications and GDRs, things to discuss with your team members now that you've gathered your team and you have your key stakeholders who are going to be providing these reviews. Think about how well they communicate. So how well do I communicate with the residents and their families when the resident does not have capacity, and other members of the team about medications and specifically psychotropic medications? Are all staff members included in education? And this includes the folks who provide care every day. These are the folks who see and are with the resident throughout the day. So I've listed a few, categories of these key persons that give care: housekeepers and food service staff, transporters, folks who work at the nursing station, the clerical staff, who see the resident, they eyeball them and they know whether they're having a bad day or there's some other concern they would bring to the attention of the nursing staff. Be aware of medication changes and discuss these potential changes with the medical team, and then advocate for using only the lowest dose necessary or none. And the reason that's there is to remind folks that staff, you should try to avoid asking to add a medication to a person's regimen to control expressions or behaviors. Next slide, please. Consultant pharmacists. So consultant pharmacists as a resource, we know that we mentioned the pharmacist role. Medication regimen review is a requirement. It's also known as the MRR, or drug regimen review, DRR. The pharmacist should be monitoring and making recommendations when it's appropriate based upon reviewing the medical record for attempts at GDRs during the monthly required medication regimen review. And I want to emphasize here that the MRR should not be the facility's only strategy for a successful GDR program. This should be a component. The consultant pharmacist does that review. It's a requirement, but don't just rely on the consultant pharmacist's review to provide this strategy. And there's a couple of, bullets here. How can you leverage your consultant pharmacist? Are you doing that? Is your consultant pharmacist available to do that? I know many times they're doing their work off-site. They may not be with you in the building. How can they assist with your process? And how could a program focusing on GDRs be implemented using consultant pharmacists as a resource? Next slide, please. So the potential for adverse outcomes related to psychotropic medication use, and again, keeping this in perspective when it comes to why we want to do GDRs, unless it's clinically contraindicated. We have FDA box warnings on antipsychotics, both the atypical, the newer ones, and the typical ones, the originals, when used for folks who have a dementia-related psychosis. So sedation occurs, there's a reduced quality of life from participation in activities. We have increased risks and falls associated with the use of these medications, falls with head injuries, huge concern for facilities. And then we know that not only antipsychotics, but other several medication categories that are psychotropics can contribute. And some other concerns relating to the use of these drugs would be the cardiac function and rhythm abnormalities and disturbances, which would require EKG monitoring. And so again, these would be the antipsychotics, antidepressants, the SSRIs, the selective serotonin reuptake inhibitors, and some other drugs. Next slide, please. So here I've included now a couple of resources. Here is one of our critical element pathways. It's available. There's a link on the slide for you about unnecessary medications. So this is essentially guidance that the surveyor is using when they're doing their survey process. We all have access to this information for education and preparation, but not only is it just to make sure we're doing everything preparing for a survey, but it's really giving us the best practice guidelines from the CMS perspective on how to do, for instance, in this case, use of psychotropic medications and gradual dose reductions. And so here, if you look, I've only included number 3 that's included in this critical element pathway, and they talk about psychotropic medications, and they do mention, was a GDR attempted? And in red, this was the newest change, tweak to this pathway. The non-pharmacological approaches were implemented unless clinically contraindicated. They also talk about PRN use, and we, of course, want to try to avoid using PRNs when it comes to psychotropics, and particularly for antipsychotics. Next slide, please. And this next resource will be the critical element pathway for the behavioral and emotional status of the resident. And again, we're talking about opportunities to provide care and recognize and acknowledge the behaviors and the emotional status of the residents. And we should be looking at this as part of the non-pharmacological interventions approaches. And here on this particular element, you can see some suggestions about care plans. So we need to incorporate non-pharmacological interventions in our care plans for the residents. And also, they give some examples about non-pharmacological interventions. So again, the bigger picture when we're doing our gradual dose reductions, are we incorporating these as elements to include in the change of care or the care plan for those residents where we would be doing gradual dose reductions. Next slide, please. What are some barriers when it comes to attempting gradual dose reductions, and what's the reluctance about? So there's some barriers that we can talk about here, and I think some of us would recognize one or more of these. Prescribers or providers who aren't confident or knowledgeable about medications and rely on the psychiatrist, or they rely on the pharmacist to make suggestions about medication changes and reductions. They're not knowledgeable and they're reluctant to change. Drug combinations, this could be a barrier with additive effects. So combinations of medications in these classes that we've talked about, psychotropics, may have additive effects that could possibly be helping the resident, but they also may be deleterious or providing bad outcomes for the resident. Although we might hear that they're used because they provide synergistic effects. They're designed, or their combinations are to be used to improve the care. This is problematic and sometimes. Medications from multiple classes being used in a cocktail fashion versus maximizing one drug or monotherapy, and really focusing on one medication, titrating it to the most appropriate dose for the resident. The prescribing cascade, or the addition or adding of medications to counteract side effects of an existing medication. So a person may be on a psychotropic, and the next thing we know, there might be observation that they're having some type of a tremor, and then another medication is added to really counteract that side effect. And this is a concern. And finally, families can be problematic when it comes to, or a barrier when it comes to having gradual dose reductions. Many times families say, don't change my loved one's medications. We don't want it to be changed. That's problematic for many reasons, but particularly for a facility where it's required to make these attempts. Next slide, please. So let's focus again on the medical record when it comes to gradual dose reductions. The medical record and orders, the diagnosis and the ICD-10 codes that are being used in the orders should be reviewed, part of the medication regimen review process, but also when MDS folks are doing their review to assure accuracy and validate that these diagnoses are accurate and correct at the time of MDS submissions, or there could be penalties for inaccuracies. And we know about schizophrenia, and we've talked about that in other talks, where schizophrenia has been improperly used as a diagnosis to circumvent the need for gradual dose reductions. And this has really been something CMS has focused on tremendously in the last 6 months or so. We also want to provide education to the facility staff, including the nursing staff, about the correct use of any diagnosis when they're ordering medications. In other words, when they're ordering the drug in the electronic medical record or in a chart, they need to know the consequences of using a diagnosis that may be inaccurate. We also want to have a dialogue and conversation, and pharmacists and the MDS team can also be front and center and dialogue with the providers and the order entry nursing staff about the diagnosis selection to make sure they're accurate. And additionally, we want to recognize that there may be appropriate uses for antipsychotic and psychotropic drugs for residents. And these residents have enduring chronic medical conditions. And a couple of examples would be bipolar disorder or depression. So we want to recognize, and we have to do a balancing act where we try to remove medications and gradual dose reduction programs, but we also recognize that some folks need these medications to have their best quality of life in the facility. Next slide, please. Some GDR strategies to promote success. So a key to a successful GDR includes notification to all disciplines. And so all of the folks that we've talked about earlier in this talk need to be notified. It's not enough for the pharmacist to make a recommendation in their medication regimen review, which suggests a GDR, and the provider agrees and changes the medication, and then nobody knows about it other than the nurse who's giving the medication sees the change. You really have to notify all the disciplines to have a success. We need to prepare for potential changes to the residents' expressions or behaviors. And how they're going to interact with their peers, especially in dementia care units. We know that changing the medication not only affects the resident, but may affect their behavior towards other residents on the unit. Tapering strategies. So here's some suggestions about tapering strategies. First, to reduce the daily dose of a medication by a gradual dose reduction. And we would say that's 10 to 25% of the dose. So if you have a dosage of 1 milligram, it may be possible to reduce it by 25% to 0.75 milligram as an example. That would be acceptable. Again, very small dose increments. Include a plan for when an additional taper could occur. And that could be, again, we will reevaluate the resident in the interim. If there's any emergent behaviors or expressions that occur, the provider would be notified, but if there aren't any, we're going to take another look at it again in the next 30 days at the next review schedule. Eliminating multiple medication cocktails, which we just talked about. That could include subtherapeutic doses of several medications. So focusing on strengthening the regimen and just removing something that can be not unnecessary to have on the regimen. And then finally, changing only one medication at a time is very helpful. Try to avoid multiple medication changes unless the resident is having an adverse effect or at high risk for an adverse outcome, such as a fall. Remember that not all gradual dose reductions will be successful. We acknowledge that. And we also acknowledge that, if they're not successful, we can always resume the medication that the resident was taking or increase the dose back. And finally, we should document the outcomes and reassess the resident in a timely manner. Next slide, please. So some pearls to ensure success, straight and simple: request reports from the provider pharmacy, access the information from the pharmacy's portals. If you're using a provider pharmacy, they would pretty much have availability to download and generate reports on these psychotropic drugs and its particular antipsychotics. Partner with the facility medical director and the health information management staff so you can create some additional review tools, audit tools that can be generated from your electronic medical record system to help verify psychiatric diagnoses when appropriate. And also the dosages of antipsychotics. Look closely at the dosages of medications that are being used with a very low dose. In general, this is a low doses are a red flag that the medications could be used for convenience. It could be used as a chemical restraint. So this would be an opportunity to recognize this medication for a gradual dose reduction or even a taper off. Next slide, please. The concept of deprescribing. So deprescribing is in vogue for the last several years. Deprescribing is a term used to help assess medications, especially for elderly residents, senior care residents who are experiencing side effects or who may be on medications for many, many years, and no one has basically, due to clinical inertia, nobody has decided to take an opportunity to reduce medications. And so today we're talking about GDRs, and we want to talk about deprescribing of psychotropics. So We talk about polypharmacy, which is a term used to describe the use of multiple medications for a residence regimen. Long-term care facilities, generally, we would say folks with 9 or more medications. Statistically, we know that's usually a pretty high number in long-term care. Regimens which are not optimized may include multiple medications within the same class. So again, we're talking about using multiple antipsychotics or multiple antidepressants from different categories. And so deep prescribing refers to a thorough, methodical, process-oriented, targeted review of medications. And this concept can be applied to a GDR program. And on the next slide, please. Here we have a resource from deepprescribing.org. And it's really for process improvement about deep prescribing. And we're putting this resource here just to highlight their information on how to incorporate improvement for the whole process when looking at how to do gradual dose reductions. You can see they're talking about folks in conversations. All the members of the healthcare team should participate. For the healthcare provider and personnel, they should all observe for signs and symptoms of changes for the people that we are providing care for. And then again, people living in nursing homes, families and caregivers should participate in shared decision-making when it comes to this medication, and perhaps even as far as consenting to changing medications or adding or reducing medications. And then the last box talks about the prescribers and the documentation, which have to include the use, goals, and timelines for each of these medications. So all of these are factors when it comes to reviewing medication regimens for and analyzing for deprescribing. Next slide, please. I'm going to include now some resources from the iPro QIN-QIO. And this first resource is an antipsychotic action plan with SMART goals. And on here, you can see that we've included the section of the action plan that speaks about SMART goals: specific, measurable, attainable, realistic, and time-bound. And on here, it's really helpful if you looked at these goals and select one. Just pick one of them. If you don't have gradual dose reduction plan in effect, and you're not having success with reducing medications, this would be really helpful if you were to look at one of these goals and implement it. Pick a goal and try to implement it with your team members to see what kind of progress you can create when it comes to reducing psychotropic drugs and folks with dementia and antipsychotics. Next slide, please. This is another resource. It's the psychotropic review worksheet. And so on the left-hand side, you can see a snapshot of the entire worksheet. And on the right-hand side, we focused in particular on the questions, which is on another page of the worksheet, about gradual dose reductions. And there are questions there. And so this is a really great resource to help you think about the questions you should be asking. This could be done by any of the key personnel that we talked about, any of the stakeholders. Is really helpful to have something to use for baseline, and then taking this and again going further after you have the data related to this worksheet. Next slide, please. This is a resource in the library that is a list. It's a list of, we talked about first generation, they're also known as typical antipsychotics, and second generation or atypical antipsychotics. And these are very commonly prescribed medications, more so in the second generation than the first. But this would be a great resource to have when we're looking at categories of drugs and, again, attempting to review for gradual dose reductions. Next slide, please. So for additional assistance, for more information, here is the email address for the iPro Nursing Home team to reach out for additional help. And the folks there are tremendous. They would always be willing to help you with any concerns, particularly around attempting to start a gradual dose reduction program at your facility if you need that. And next slide, please. And again, this is the closing out for the QIN-QIO. Again, for more information, and to stay connected with us, please feel free to connect with us on this link and look at the many resources that we can provide for your facility's needs and for you as well. So I want to thank you for attending today's presentation, and I will turn it back to our host.